Hello, everyone. I'm Rose Gerber, COA's Director of Patient Advocacy and Education. Thank you for joining us for today's Advocacy Chat, educational conversations on healthcare and policy. October is American Pharmacists Month, which is a great opportunity to shine the light on the important work done by pharmacists. The American Pharmacists Association created this event, and every year they also develop a new theme. This year, the theme is Caring for Our Communities, which I thought was a perfect description for the work that the pharmacists do in a community oncology setting. What you'll learn today is that their role is expansive and includes patient care and also contributing in a variety of ways to different members of the care team. They also advocate for cancer patients at the state and national level. And you know, no advocacy chat is complete unless I mention COA's obsession, which is PBMs. So they'll give us a little bit of insight into that as well. Today, our special guests are Judy Alberto, COA's Director of Clinical Initiatives, who you all got to meet for the first time last year, and Lisa Raff, Vice President of Pharmacy Services for Oncology. I'm really looking forward to their conversation today. We'll learn a lot. For most people, the only role that we really see a pharmacist in, which is also very valuable, is retail. So today we're going to learn another side of pharmacy. And I'm going to go ahead and start with you, Judy. And can you just give us an overview of your current role? And then we'll go ahead and get into some of the questions.
Sure. Thank you, Rose. And very happy to be here today and with Lisa, my colleague as well. So as you said, I'm Director of Clinical Initiatives for COA. This was a new role that was created when I was hired 2 years ago. It'll be 2 years now, the end of this month. Very unconventional role. So I am a pharmacist by training, really focused here at COA on education, overseeing the pharmacist network, really new launching our APP network, do a lot with the clinically integrated network. And then a lot on, like you said, Rose, PBM work and policy work. And so we're up on the Hill and we're helping others in this same scenario that are working as pharmacists, but also want to make an impact. And so really learning about that, because it's not something that I was taught in pharmacy school or ever did in any of my prior experience. So learning a lot and seeing the value and the impact that that has on our cancer patients is really extraordinary. And COA is just such a powerhouse when it comes to being a voice in DC and lobbying and helping in that area. So happy to be with you today. Thank you for having us.
Thank you, Judy. You've been a great addition to the team. Lisa, can you also tell us about your role?
Sure. Hi, everyone. Lisa Raff. I lead pharmacy services at Oncology. I've been there almost, actually just a little over 3 years. So I have a clinical arm that I oversee where we run pharmacy and therapeutics committees, pathways, which really drive excellent patient care across our network, an operational arm where we help with, as Judy has mentioned, PBM and getting more insight into what our practices, our community oncology practices are feeling. Mixing, and then couldn't agree more with Judy. I spend a lot of time on advocacy with Oncology and COPA, and it's phenomenal how much COA and COPA have taught me on advocacy, because again, as Judy said, this is not something they teach you when you're in pharmacy school. And along with that, while you might take some business classes, I don't know that anyone really teaches you at a granular level of running an IOD and contracts. So being a part of the COPA network really helps to teach me and help me teach others.
Okay, thank you. Thank you very much, Lisa. And before we get to our actual real questions, and if I can have the slide go backwards one, you mentioned two quick things, pathways. Can you quickly describe what that means to people who may not know? And I think I heard the acronym IOD. Is that what I heard?
Yeah.
You also, so we're going to be really, when we all hear acronyms, we're going to break those down. So if you can answer those two questions, and then if we could get the other slide up.
Sure, definitely. So pathways, what pathways are those are treatment decision pathways inside of a clinical tool. So when physicians go to order drugs, we build a tool with Oncology pathways, which helps providers understand what treatment options are available for those patients. We know that oncology is changing literally every 24 hours. So these are written pathways that say for breast cancer, adjuvant treatment, we give X, Y, and Z. So those are pathways. And IOD is in-office dispensing, so filling prescriptions within your practice that you can dispense to your patients.
And that's a very important issue that we can come back to later as well. Thank you, Lisa. So who wants to take this first question? We know I start off by saying that for most individuals, myself included, the majority of times when we see pharmacists, it is in the retail setting. So how has the role of a pharmacist changed in the last couple of decades, and why has that changed?
Yeah, I'm happy to kick that off if you're okay with that, Judy.
Absolutely.
So yeah, I think it's, it's a perception. You go to Walgreens, Costco, and you see a pharmacist behind the counter. What a lot of people don't realize is pharmacists get their doctorate. A lot of us do residency training after we complete our doctorate. A lot of us go for various board certifications. It can be in pharmacotherapy, oncology, and we are really a critical part of the care team when it comes to helping dose medications or someone's kidneys or liver not working well. Do we see their blood counts really low with treatment? So do we need to adjust those treatments? If a patient isn't feeling well, if they're nauseous after treatment, or if they're very fatigued, do we have to give medications to help their blood counts? So we're an integral part of the team that, that's the clinical aspect. We also do things such as regimen building to make sure that when the physician goes into their system to order medications, that the appropriate doses are programmed within the system. So we really have, it's not just adjudicating claims. And what I mean by that, it's not just sending claims through. We really start from A to Z before the patient's even seen. Do we have appropriate regimens? Once the patient is seen, are we adjusting for all the factors that, the patient's that needs to be accounted for? And then afterwards, are there adverse events, or is this a regimen that's not working or helping to treat the patients? And to add to those complexities, which is great, we have so many more options now based on molecular biomarkers. I'm sure a lot of you have heard like lung cancer and EGFR, only because there's commercials all of the time. We have so many of those biomarkers now that pharmacists have to help keep track of to make sure that we're offering these what we call targeted therapies to patients. So that's, that's the clinical perspective. And I'll pause because I'm sure Judy would like to add some color to that.
Yeah, I agree, with what Lisa's saying. I think historically, pharmacists are seen as being in a retail setting, and people think they're counting tablets, they're counting pills, and that's really the extent of what we do. And I think historically we had those two choices. We were either in a retail setting or we were in the basement of a hospital. And I think what we've seen is we've really grown, and we're really the unsung hero because you don't see a lot of what the pharmacist does. So we're very behind the scenes, making a difference, checking the orders, like Lisa said, looking at the dosing, looking at biomarkers, looking at what would be the most appropriate therapy. And so because oral, especially oral, has become so much more available now to our cancer patients, and even our IV therapy has become so much more complex, the role of the pharmacist has really grown. And it's so critical that we're a part of that care team, and we're offering our expertise because we're the experts in medication management, not just dispensing, but being in that care continuum, role that we are helping from diagnosis all the way through to survivorship. Just like Lisa said, every part of the way. We're really the glue that holds that together and is not always seen, but you can feel when a pharmacist isn't. Lisa, I'm sure you can attest to, when there might not be a pharmacist in a certain model, how the rest of the care team, it's a burden for them to really pick up that slack of that medication management, that therapy. We're those experts. That's our training.
Yeah, definitely. I mean, the education we provide, again, it starts at staff level, family member level. Sometimes patients, will have questions while they're receiving their treatment. And that's that's what we're trained in, is to know the adverse events and know why the drugs work, or if they're not working, potentially is there a drug interaction, a food interaction. So we help with education. And I think another huge area is expanded access. Sometimes we know it does take time for drugs to get approved through the Food and Drug Administration, the FDA. And so, I can say I had a personal experience. We had a patient progressing with a very rare cancer. And while it was in the late stages of FDA approval, I worked with the manufacturer and the FDA to get that patient that drug. So that's a huge, I mean, we know community oncology clinics are busy. It's hard for nurses and physicians to keep up. And so to have a pharmacist who can work closely and really understand what's involved in these expanded access programs, excuse me, and the education that is needed is critical.
And I think to your point, Lisa, when we work to the top of our license like that, it allows nursing and physicians, technicians to also work to the top of their license. And so, you know, we are that support tool. We're that person that makes a difference to support, make sure that everybody is able to work to the top of their license and do what they do best.
By the way, I love that expression, the top of their license, and I'm glad that you both started off by talking about the credentials that you have, the education that you have, because I am sure I speak for most patients, is that it's very comforting knowing that there is an oncologist double checking everything. I mean, we all know that nurses are very much loved. We all love our nurses and trust the nurses, but the pharmacists, you know, are right there. I also want to remind anybody in the audience to feel free to put any questions in the chat, or if you have anything that you'd like to share, we'd love to hear that too. Let me ask you about the dynamics of a practice, because not every practice has an in-house pharmacy, right? So tell me why that is better, why it's more challenging. Is there any, because we're here to learn, is there any friction at any time, you know, where maybe the pharmacist has to push a little bit harder, or what is the structure basically? How do those dynamics work?
Do you want to jump in, Lisa? And then
Sure,
I'll-
definitely.
Yeah.
So, you know, in my own practice, when I was in my own practice, and now even within One Oncology, it is so important to have in-office dispensing. As Judy was saying, what we call oral oncolytics, so oral medications for cancer therapy, they are really the future. We're going to see more and more of them. But everyone has this kind of notion that, oh, if I'm taking it by mouth, it's not going to make me sick. I'll feel okay. And that's exactly the opposite with a lot of these agents. They can cause skin toxicities. Again, you can have low blood counts. You can have ocular toxicities. So when we are able to keep these prescriptions within a practice, it means it's allowing the pharmacist, the nursing staff, the physician staff to really track, okay, this is when the patient received their medication. This is when the patient started taking their medication. Okay, then they developed this toxicity. And so they can go back and see, okay, well, it was at this dose at this time. So now maybe we can start considering, okay, maybe we need to dose reduce. And so having that close touch, and I can't explain enough, it's really hard when we're forced to send a prescription out to, you know, an outside pharmacy. We don't know when our patients are getting their medication. So if they get a toxicity, we don't know, is it their cancer getting worse, or is it they've been on their medication longer than we thought, or worse, have they only been on this oral agent for 2 days and they're just getting this sick this quickly? So it's really important for patient management so we can provide the best care to our patients. Second, a lot of times what happens is these oral agents are very expensive. And so external pharmacies, I don't feel are as passionate as we are about finding the grants, the funds, the copay cards for our commercial patients that allow our patients to receive their therapy in a more timely manner. And there have been several studies done showing and demonstrating that when a practice fills their own prescriptions, patients start treatment sooner and have less financial toxicity. One, because we're not auto refilling a medication, we're checking to see how they're doing. Do they need a refill? Has it been held? As far as tensions, you know, I have to be honest, I don't see any tensions of anything. It brings a practice closer. It makes you work closer together with your nursing staff and your physician staff. We can help with those prior authorizations and the toxicity management.
I think the tension and sorry, just to elaborate a little bit on what Lisa said, you know, maybe that tension is when you're forced to send those prescriptions out, you know, due to vertical integration and what's happening with the PBMs. And so, Lisa, I love your point with the oral oncolytics, because I think so many people think it's so safe. And when we have patients in for IV infusion, you're monitoring that. You're giving those pre-meds. You're monitoring while they're sitting in a chair, their side effects. But you can't do that with an oral oncolytic. And it's no different. They're still very toxic, to Lisa's point. And so when you're in this environment with this interoffice dispensing, you really see the whole picture, and you can do so much more handholding with your patients that you can't do when you're using an external PBM that's just mailing you a prescription and there's no face on the other end of that. You don't know that person. You don't know their family. You don't know their history, and so you do so much more handholding, and patients love to see their pharmacy. Again, to Lisa's point, I know I would be very anxious if I had to get chemotherapy, and being able to see the pharmacist who's handling that, who knows the side effects, who I can talk to about, what I might be experiencing, and have immediate access to that person, I would feel a lot more comfortable. And they do. Patients, I've known patients to call the pharmacist on their cell phone to say, this is what I'm experiencing. I have some mouth sores, or I want to start taking some herbal treatments, or herbal tea. Can I drink this? And they call, and they're just such experts in that, and patients feel really comforted by that.
I mean, the amount of responsibility you have is absolutely staggering, but I know patients absolutely appreciate this. So you both in your own way mentioned two very important things. That's a great thing to talk about. One is prior authorization, and one is the issue with PBMs. So the way I like to treat every single one of these advocacy chats is that there's someone brand new who has no idea what that means. So address the issue about the difference between having a drug in-house and then sending out that prescription. What does that mean to the patient? And the prior authorization, how that affects patient care.
So I'll just jump in really quickly. I think when you hear, for somebody who really doesn't know what it means to send a prescription out, it may sound like a great thing. Oh, my prescription's going to be mailed to me. I don't have to do anything. But it doesn't take into account what kind of handholding and what kind of oversight is necessary when you're taking oral chemo. And so that prescription could take up to 2 weeks or more to get to you. And when you have a cancer diagnosis, the last thing you want to do is delay your treatment. It could cause progression. It could be the difference between curative, or now you don't have that option anymore because you've progressed. And so every day matters. And we've seen when your prescriptions are sent out, it takes a lot longer to get the prescription. And there's not one person in that pharmacy that's monitoring your labs when it's sent out to a PBM. They're not looking at that, your weekly labs or your monthly labs. They're not looking at if it needs to be dose reduced and what kind of side effects. They just keep sending it, and they just keep getting refills. And so that could be very confusing to a patient who is maybe having side effects. They're not sure what it is. They're not sure if they should call the office. And then it keeps being sent to them. They don't know, should they still continue to take this? Even if they were told by their physician not to, if it shows up in the mail again, it could be very confusing what to do. Sometimes you need to take a week break, and that could be very confusing. And if you're not talking to your pharmacist, like right in person, like, every day like that, can be very confusing. And so, that's the difference between staying in-house in your IODs or a prescription being sent out to a larger PBM that doesn't have that kind of oversight.
Yeah, and I'm glad you mentioned the point about how it would be very easy to only focus on the convenience of it, because we all order from Amazon, and just having things delivered to your doorstep sounds great.
Yes.
But what you're doing now is teaching us about things that I know I never thought of before working for COA. We've all heard stories, or maybe not everyone in the audience, but maybe you can also talk about that, about drug waste. So you've definitely talked about the patient impact, but talk about what this means to the healthcare system and the costs involved when you're continually sending those medications.
Yeah, so as I mentioned earlier, Judy and I looked at a couple studies where it really does demonstrate, because to Judy's point, I even get calls from my local CVS. I'm like, well, wait, I don't need this right now. They have what's called, an auto refill. So they'll just, every, let's say 25 days, send a medication out, because they're like, look, the patient needs this, so we need to send this out to them. To Judy's point, sometimes we know patients progress, unfortunately, on treatment. And so if they progress on treatment, they should no longer be taking that medication. The PBM doesn't know that, and then they're sending it, and we run the risk of, one, is the patient going to continue to take the medication? Or two, once that medication is sent to the patient, this is where the waste comes in. A patient can't return that medication, because once it's left the IOD or the PBM, just to be clear for everyone, a pharmacy can't take it back because of, safety concerns. So that's where the waste comes in, as you continue to have these medications sent. And if the patient's no longer on that dose or no longer on that therapy, we just waste those medications.
Yeah.
And you said the cost of drugs is staggering, I'm sure.
It
I'm just,
is.
is there any kind
Staggering.
of a ballpark figure, if you had to say a cancer medication, maybe for unfortunately one of the most common diseases, what the therapy cost would look like for a year?
I mean, I can tell you for a month, a lot of these oral agents can be around $15,000
A month.
or a month.
That's incredible. We have two questions that I'd like to address, and thank you for sending them in. We'll start with the first one. What methods of communication do patients have when reaching out to the pharmacist? Is it mostly in person? And I'm assuming this is in the community oncology setting. Can you both address
So,
that?
I mean, yeah, you can, when I was in my practice and definitely my pharmacist now, no, it doesn't have to be just in person. You can call them.
Mhm.
A lot of times, patients had my pager number because I carried a pager, or there's the central IOD or pharmacy number. So you can call your pharmacist and say, hey, I have a question. This is happening. I'm not feeling well. And it's really easy. A lot of pharmacists know how to manage those toxicities. They can go back to the doctor, make a recommendation, and get right back in contact with the patient. So in person is great, but no, there are definitely, and there's also, ways to email. So email, call, in person.
Absolutely.
Would you like to add
Yep.
anything, Judy?
No,
Okay.
agreed. I think they have immediate access to the pharmacist, and that's what's so important here and a lot of times they're on a first name basis. They know their pharmacist and their pharmacist knows them very well.
And again, I know that that's got to be very, very comforting for patients. Next question, how are you able to dispense in-house? We have a specialty pharmacy within our health system, but it is not located within our hospital.
So that's the difference if it's a hospital health system versus if it's a privately owned independent community oncology practice. And so you can have that in-house pharmacy or in-house dispensing within the physician practice. A hospital system does have specialty pharmacies that may be on site or could be off site somewhere else. So it really depends on what your system is and what that looks like. But both exist.
Okay. Lisa, did you
Yeah.
want to add anything to that?
No, I think Judy's right. She's spot on there.
Okay. The next question comment is, I might have missed it, but can we touch on having an in-house pharmacist with IV drugs? It's a hot topic with our infusion team right now.
So I guess I'm going to try to clarify on having an in-house pharmacist with IV drugs. Yeah, I definitely think it's beneficial. And what the practice should look at is it's not just managing those IV drugs. You could potentially open an IOD that they could oversee. I think it's so important. I would spend hours of my day adjusting drug dosages, as I talked about earlier, helping manage toxicities. That frees up physician, advanced practitioner, and nursing time. So I know a lot of the times, because we are licensed individuals, everyone's like, it's really expensive. But I think what you have to go back and look at is it's really not that expensive if that physician can see an extra patient, that APP can take care of what they need to, that nurse can go and treat their patients. And we can answer questions of the care team, help with, what we talked about, prior authorization paperwork, which is paperwork that we have to fill out before patients can get their medications. So there are a lot of places that pharmacists can touch and alleviate some of the stressors on the system.
And to expand on that, agree with Lisa. We've had this conversation. Lisa and I work very closely together, and we hear people say can't afford a pharmacist on staff. And we always say you can't afford not to have a pharmacist on staff. And so, yes, even in the IV infusion, if you put a pharmacist in clinic, then they're helping with that decision support. They're helping not only enter into the pathway, your clinical staging and your decision making, but also they're building that pathway. They're overseeing that the pathway is correct. They're in the EMR, making sure that the process is working very smoothly. And so before the patient even gets in the chair at an infusion center, when you have that inter-office situation, your order is ready to go. You've looked at all of your labs. The pharmacist has double checked all of that. If anybody's on the call that knows about carboplatin dosing is very complicated and there's a lot of leeway. And so you can have your pharmacist look at that, dose that with your kidney function in mind, cuts down on so much delays and work while you're in the infusion center. I did want to mention, we also see PBMs getting involved in infusion. And so they force white bagging. that also causes an extreme amount of waste, probably up to, depending on how many patients you're seeing, could be 1 million a year. You could be tens of thousands a month in just wasted drug that piles up when patients have been stopped. So I think everything we've been saying about the oral can be extrapolated to the IV infusion, both the benefits and some of the downside as well that we've been talking about.
Thank you. So you mentioned white bagging. I know some people have heard of brown bagging. We're here to learn. So tell us what's the difference between white bagging and brown bagging.
So brown bagging should never, ever, ever. In brown bagging, it's sent to the patient's home. And we say brown bagging because then they put it in a little brown lunch bag and bring it in. And we can never, ever authenticate that product once it doesn't, that chain of custody doesn't stay within the pharmacy. So that should never be allowed. White bagging, we'd love to push back on, but sometimes you can't. And so the PBM is mandating or forcing it to come to your infusion center. Sometimes it can come to the physician's office, but again, if things have to be refrigerated, it needs to stay within that appropriate chain of custody. And so you'd like to set it up so it comes directly to the pharmacy so we can ensure that it's at the right temperature. And then if you are in a health system, clear bagging. Yep, clear bagging. If you're in a health system and the specialty sends it to you, that would be clear bagging. Go ahead, Lisa.
And I was just going to say here, you should all push back even with white bagging, to Judy's point.
Agreed.
Sometimes there are no ways out, but it's really encouraged to have a policy saying that you don't accept brown bag or white bag medications.
And sometimes a pushback that's all it takes.
Mhm.
And they'll go, they'll say, okay, they'll also agree not to white bag. So it's worth a try.
This is very good. And I'm always hoping that, people are taking notes, but if not, because there's so much that we're learning today, just a reminder that our slides is going to be available on our YouTube page. So definitely take a look at it. We have a couple more comments I want to go through. One is, not sure if this is going to be touched on at all, but is COA involved in state legislature for making accumulators illegal? I am in a state where accumulators are legal, Idaho. I would like to get involved with creating legislature working towards making accumulators illegal. Is anyone else doing this? And I know that's a pretty complex topic. So if you wanted to give a brief.
Yes, I think we are working on, that's part of the policy that we'll be looking at for 2025. We work with our counsel, and yes, and when we're on the Hill, this is something that does come up. And we would like to tackle this in the future for sure.
And that's just a quick reminder that, COA now, we're 21 years in existence, but for the majority of COA's existence, we were really focused on federal policy. We have definitely heard from our members that the issues taking place at the state were very important. So now we are focusing more on the state issues.
And we'll be focusing on state issues coming. I just sent out a survey and to some, and the rest to the listserv will be going out later this week to see what we would like to focus on for 2025. But definitely state issues will be something that we will continue to monitor and to bring up on our COPA call. So we're going to look at the different quadrants of our country nationally, and we'll be addressing them.
And what is COPA, Miss Judy?
So COPA is our Community Oncology Pharmacists Association, where Lisa is a board member, and we bring different topics every month. We focus on state, we focus on Hill, we do some drug updates, we do some legal updates, and then we'll have a main presenter of all different sorts. So when that survey comes out, if you're a COPA member, please fill it out. If you're not a COPA member, please join.
Thank you. And we have one more comment, and just a reminder, I wish we could go on and on, but this is designed to spark your interest, and go online, learn about white bagging, brown bagging, clear bagging, copay accumulators, all these different acronyms, EMR, everything that you want to know. Just it's a great learning opportunity. We have a comment here from another individual. I work for a patient advocacy organization. We are always looking for providers who are willing to check biomarker test results and ensure patients understand their results and are placed on the accurate treatment. What role does the pharmacist play in this?
So I can take this. I actually went during COVID. I guess you could say I was bored, and I went and got my master's in personalized medicine. So essentially what that meant is I got my master's in pharmacogenomics. Wow. And then, biomarkers. So pharmacists are very well versed in reading what we call next generation sequencing reports, or NGS reports, that show, hey, your cancer has this biomarker. and these are the new targeted therapies. But what we also know is NGS reports are outdated so quickly because new drugs get approved so rapidly. So pharmacists are able to go in, look at these NGS reports and identify therapies that patients, you know, potentially could qualify for depending where they are in their treatment journey. So we're very involved with that.
Thank you. And this brings us to our end. I want to thank Judy and Lisa for sharing your skills and knowledge with us. And I want to thank all the participants who've sent in questions and just for joining us every month. We really appreciate your participation. We have one last slide, and then we will say our final goodbyes. So next month, we have our special guest is Kathy Ube. Many of you know her. She's well known in the national oncology space as well. She's the Chief Operating Officer from Pontchartrain Cancer Center. And we're going to be talking about open enrollment because anybody that has a TV or does anything online, we know we keep seeing all these annoying commercials. But this one will be a very important talk for us to learn from. So thank you all for joining us and enjoy the rest of your day.